Hi, everybody. Welcome to the last segment of our TV show. We're going to talk about hepatitis co-infection, new data or new information that may have come up here at the conference, although there wasn't much. But we're going to talk about hepatitis C and hepatitis B co-infection, which is probably, in my opinion, certainly, the #1 problem in HIV today. Even though the national numbers are about 30% of people with HIV have Hep C and probably 5 or 7% have hepatitis B. Amongst the populations that are most affected by hepatitis C, particularly individuals who get their care through Ryan White funded programs, it's probably 50% or more that have hepatitis C. It's the leading cause of death and hospitalizations in HIV except for AIDS. Unfortunately, it doesn't get the attention it deserves, and nor the funding from Washington or from states. So we're here to talk about treatment and care and maybe what new information we may have learned at this conference. And the reason I say it wasn't very much is because most of the good information regarding hepatitis C comes from studies in monoinfection, which get presented at liver conferences. Frankly, except for our guest, most HIV docs don't know that much about hepatitis C, well, they do know a little bit more about hepatitis B, but not that much either. So you have to be very careful about where you get your information, and be careful about the kind of care that you get. Try and make sure that whoever is giving you your care, make sure they understand hepatitis C and co-infection. So let's move ahead. I'll introduce our guest today, Dr. Jay Kostman from the University of Pennsylvania.
Thank you. It's nice to be here and discuss this with you.
So I think it's my second year doing this cable TV show. It's always a pleasure, and I always like talking about hepatitis. By the way, I've had HIV for 20 years, and I'm cured of hepatitis C after having completed a total of about 2 years on therapy, with a year and a half finished 2 years ago with PEG interferon and ribavirin, and I'm cured. Yes, cured. That's the word. If you haven't heard it, Hep C is curable. It's 2 years now. And just one last comment. I've never felt better in my life. Now that the Hep C is gone, I have more energy, more mental, what's the word? Mental clarity than ever before. So, Dr. Kostman, what would you think coming out of this meeting? What would you like to say? Any particular studies you'd like to highlight, or how would you like to start off?
Well, I think as you mentioned, there is not a whole lot of new information, and I think some of the things that were most important were studies that were presented that I think we need to clarify and put the right spin on, so to speak, and by that I don't mean change the message, but make sure the correct message gets out. So we can start maybe by talking about a study that came from Johns Hopkins that is really one that we need to get the message out on. And that was a study where they looked at their population. This is a very well-defined population, thousands of patients, about, as you mentioned, 30 to 35% of which are co-infected with hepatitis C. And they presented information on how few of these people actually get not only treated, but in the end get cured of their disease. And the reason why the number is so few of those who get cured is because not a lot get treated. And so I think the message of that, going down from 900 or so patients who would be potentially eligible for treatment because they have hepatitis C, and then for various reasons only 10 to 15% of them maybe get evaluated for treatment and then started on treatment, and only less than 10 end up being cured of that number. So I look at that to say, wow, we need to do much better at getting treatment to people who need it, and where we need to work on is how do we get those people treated and how do we get them through treatment. So I think the message of that study is really the challenge to us as providers is we need to work on systems that can do that.
And so let's talk about that for a minute. Myself, I have, as I mentioned, taken PEG interferon ribavirin therapy for a total, 2 different times, total of about 2 years, and it is difficult to tolerate. Would you please comment on how you, as a treating physician, prepare your patients maybe to be ready to therapy, to make the decision to consider it and to do it, and how you help them make that decision and get through therapy, and maybe a few words about when you like to start therapy in the co-infected patient, because these are all very critical questions. And one reason that it's also important is because for people who are listening to this, maybe they can learn from how, if you're a patient, how you can get through this process, or if you're a doctor or a care provider, how you can help your patient get through it. So go ahead.
I think those are all very important questions, and it starts by being aware that hepatitis C is an important problem in this population, and so therefore we have to test people. And that sounds like an easy thing, and you wouldn't be surprised, but people out there may be surprised that that is still not done universally, that people who are in practices receiving HIV care are not universally offered hepatitis C testing, and that is something that definitely should be done. So the beginning part is testing people and using the right test, not to go into detail about that, but being sure that you've done the right test to determine someone truly has active hepatitis C infection, whether that's an antibody test or a test that's directly measuring the virus, which you might use in certain situations. And then I think, again, incumbent on us as providers is, once we identify those people, is not to use our own potential biases to say this person might not be a good candidate for treatment because of a history of substance abuse that might be in the distant past, or a history of depression which might be adequately taken care of now. Traditionally, those are the kinds of people that might be excluded from treatment, and they shouldn't be. We need to make efforts to include those people. So how do we do that? Well, I think part of it is educating, sitting down. What we do is once we make the diagnosis and determine someone has chronic hepatitis C, we have the patient sit down with an individual. In our setting, it's either one of the physician providers or a nurse practitioner who is particularly experienced in both dealing with patients with hepatitis C and getting them through treatment, to go through a session where they sit in an appointment and talk about the natural history of hepatitis C and why it's so important, what they need to do to modify some things they might be doing in their life, the importance of no alcohol in this situation, because as we know, alcohol is the most important hepatotoxin that we are exposed to. The use of alternative therapies, what they're taking, what they might take, consideration of milk thistle if they're interested in that. So really getting down and giving people information so that they understand, talking about sexual transmission and what they might need or not need to change in their own lifestyle. And then once you go through that, talking about what you need to do to assess how extensive their disease is, which in my opinion is to do a liver biopsy. I think that people should get liver biopsies because it's really the only way we know to know for sure what's going on in the liver. There are some other tests. There were studies presented here looking at some laboratory tests to measure fibrosis or to predict fibrosis. And some of those may be useful, but I personally don't believe they take the place of a liver biopsy.
They're not ready for prime time yet.
I don't believe so.
I don't believe so either.
They're useful to look at in studies. We may learn more about them in comparison with liver biopsies, but I think they have to be done where you're comparing it to the gold standard, which is a biopsy. And then once you get to that point, getting that information and saying, okay, this is where your liver is now. You have this much fibrosis. My worry is, because we know that HIV accelerates the progression of fibrosis, that even in people with early stage fibrosis, that's actually the best group to try to approach for treatment, because those are the people who are going to have better response rates potentially, and in whom you might be able to make the greatest impact. And so making people understand that even though, okay, it's good, your liver is not that scarred, but now is the time we may need to intervene. And then getting people through treatment. From a provider standpoint, you have to be available for patients. That's the key, is because you have to explain to them side effects, and then you have to know that they can call you and say, God, I feel like crap after this week. And you can say, okay, let's do this instead. Let's change the time that you inject. Let's have you come in and we'll give you your injection. Let's use a non-steroidal beforehand. Let's make sure you're hydrated. But you have to be open. You have to have that line of communication open. And in our setting, we do that by having a very experienced nurse practitioner who is basically on call for everybody who's being treated. You know, they have her beeper number, they have her phone number, and they know they can reach her.
Well, when you have a patient, and I'm sure you do have many of these because everybody does, who's really afraid of the side effects, how do you evaluate whether they really need to start therapy, and how do you persuade them to start therapy? What are some of the issues that come up?
So some of the issues that come up are, and you asked about this in terms of timing of therapy in relation to their
Right.
HIV disease in particular, which is an important one. So that's one of the things I look at. I look at where their HIV disease stage-wise is and where their hepatitis is. And the traditional approach to this is, okay, if the HIV disease is either well controlled on drug, to me, that's a little easier decision because you're already controlling that, and then it becomes, okay, let's deal with your hepatitis now. And then I actually try to be pretty aggressive with individuals and say, I know that you might have heard bad things about this drug. I understand that. Let's sit down. Let's have you talk to someone who's gone through treatment. Let's have you talk to someone who's had a biopsy and get you some information on that. Let's have you go to a support group, not just a support group for people who have the virus, but for those who are undergoing treatment. I think a lot of the emphasis on support groups has been just understanding the infection. Our experience is a support group where individuals are being treated is really helpful, just to help share their own experiences.
You have a support group at your place?
Yes.
And so I think that one of the important issues is, it sounds like this is how you approach it, to treat early rather than wait. So somebody does a liver biopsy, which can be graded from 0, which is no fibrosis, no liver disease, to 1, which is minimal, 2 in the middle, 3 almost cirrhosis, 4 cirrhosis. When do you like to start therapy? At one point?
My general approach, and this is really individualized, as you well know.
Well, they have to be ready too.
So right, so they have to be ready. If they do have depression, it has to be controlled. Control as much other factors as you can, but all of those things done, I like to start when someone is either stage 1 or 2, preferably 1. Because, as I said before, the earlier in disease you start, I think the better chance of response.
Now, this is a very important point because people like to put off therapy because they're afraid of the side effects and so forth, understandably. So why do you want to treat so early in stage 1?
I think there's several reasons. One is that we know that response rates to treatment are better the earlier you start in disease. So, yeah, and that's for several reasons. One, because I think this may be the major one, is treatment is more tolerable the earlier you are in disease. A lot of the side effects, particularly some of the laboratory abnormalities and the blood count abnormalities that we see with interferon and ribavirin, are more common with more advanced disease. So I think you're better able to get full doses of treatment into someone earlier in disease. And I think that's important. I'm a big believer in don't modify the dose of treatment. Do what you can to get somebody to get a full dose of treatment at the optimal dose that you can. And those people, you can do that earlier in disease.
Now, let me ask you an important point that just came up at the recent ICAC meeting, which we knew before anyway, but they showed some data from the apricot study, which was Pegasus ribavirin, and it was related to adherence. And as some people may know, the data from the studies, the apricot study showed overall about a 40% cure rate, sustained viral response. It was, I think, 29% in genotype 1 and about 65% in genotype 2. But they showed data on adherence. And there was a tremendous difference in the response rates between people who were close to 100% adherence or greater than 80% or 70% and people who were less than 80%. If I recall correctly, people who with genotype 1, it was something like 40% versus 10% or less with adherence. And if you have 90 or 100% adherence, it goes up even more than 80%. So could you comment? The reason I bring this up is because patients hear the data and they hear, well, 30% of people get cured, it's not worth it for me. But that doesn't really speak to the truth in terms of how you can respond.
And I think adherence, that's a really important point. As I was mentioning, the most drug you can give, the optimizing doses is very important. And so when the studies that have looked at adherence in hepatitis C are not as far evolved as those that have looked at it in HIV, because adherence isn't measured in the same way. But your point, I think, is still the right one, which is if you can emphasize to individuals, to patients, to your patients that not missing doses of pills of the ribavirin is extremely important, and whatever you do, don't miss the injection. And sometimes that means coming in weekly to get it if people are a little uneasy about doing it at home. So we have to adapt as providers to deal with that. And the other point is, some of the traditional approach to hepatitis C treatment is to modify the doses of the drugs based on toxicities. People get bad anemia, cut back the dose of ribavirin.
Well, do you use EPO?
So my approach would be more, don't cut back the dose, but do what you can to maintain the dose, and that's using erythropoietin. Sometimes even if you can, from an insurance standpoint, get it up front in people who you judge to be at risk for really dropping their hemoglobin early, is to use the erythropoietin at the beginning of therapy to prevent the drop. And there aren't great studies that show that using that leads to improvement in SVR, in cure, but there are studies that show that using it will result in more ribavirin.
And makes it more tolerable,
and
quality of life on therapy.
And I believe that that's true. That quality of life on therapy is a very important point. The other thing is just that you mentioned in the beginning about yourself, which is, I think, really important, is quality of life after treatment. This is a hard disease because it's hard to convince somebody going on interferon that during therapy their quality of life is going to improve, just because this is tough therapy. You can get through it. But I think what you have to focus on is that your goal is to cure, and by curing, in the long run, because we're looking at this in the long run, that will improve your quality of life.
And you might live longer.
And you will avoid complications and live longer.
And not die earlier.
Yeah.
So let's move to a different topic here. There was a poster here talking about fatty liver, which is the accumulation of fat in the liver. And so I think this is a very important topic, mainly because very few patients and doctors know about it, what it is and what are the implications and how to address it. So in brief, fatty liver can happen anywhere in 30 to 60% of the general population in general. And the question is, can fatty liver happen more often to people with HIV and more often to people that have co-infection? And the reason I'm bringing it up is not just to educate on this issue, and we'll ask the doctor how he addresses this and how he treats it, but it's important to be aware of it, because what the poster showed, which I think was a poor study and bad information, what they showed is that there was no difference in the number of people who had fatty liver who were on HAART compared to people who were not on HAART, people who didn't have HIV. And I believe that's misinformation, because the study wasn't properly done. Tell us, what are the risk factors for having fatty liver, and a little bit about what you think about it and how you might address it in terms of improving it.
So I think the real implication of fatty liver first is that fat in the liver is not a potential, but it is something that will induce more inflammation around the liver. And so it's not just a matter of seeing the fat in there like you would see fat in other parts of the body. It's that fat accumulates in the liver and then results in more inflammation around that, and that will lead to more and progressive fibrosis in the liver. So think of it as another thing going on in your liver, which is going to cause your liver to get worse over time. And so, and we know this from even before HIV infection, there is an entity called NASH, or non-alcoholic steatohepatitis, which is fat in the liver, which was traditionally seen in obese women and led not just to fat in the liver, but to hepatitis, to inflammation. So we know this exists. My experience clinically is that fatty liver is more common in people with co-infection compared to people with mono-infection, and that's from just looking at a lot of liver biopsies of people both mono-infected and co-infected. The study that you referred to, which took a cohort of co-infected and mono-infected people, I think is limited by several things, including a very huge bias on who got their liver biopsies to begin with, and why these people, particularly those just with co-infection rather, would have gotten biopsied, and probably eliminated a large percentage of people who these investigators said, oh, I won't treat them anyway, so therefore I won't biopsy them, and those would be a group of people who may even be more likely to have fatty liver. So my experience is that fat is more common in co-infected people. In addition to increased BMI or increased weight being one of the major contributors to fatty liver, diabetes and insulin resistance is another one. Alcohol is another thing that predisposes to fatty liver, and there may be other medications. The ones most important in the HIV community are the reverse transcriptase inhibitors, for which there is some information that I think is fairly convincing, particularly with the D drugs, D4T in particular, and DDI maybe to some degree, that because of mitochondrial toxicity may lead to increased fat in the liver.
Now, if you do a liver biopsy and you find a patient has fatty liver, how do you address it clinically?
It can be a very difficult thing to approach because there are not standards to do this, but I think there are there are common sense things and then some data supported things that you can do. Certainly you have to emphasize to people if they are drinking that you have to eliminate alcohol. And this is another, and I know that's a lot easier said than done, but this is an impetus to really make efforts to say, this is going to shorten your life if you continue to do that. If people are hyperglycemic, even if they're not frankly diabetic, then interventions which may be dietary, and dietary are probably the first kind of interventions that you're going to want to make, and that's talking to a good nutritionist, dietitian about changing, first getting what their dietary habits are and then changing them to decrease fat intake or decrease things that may result in fat accumulation. Oftentimes there are lipid abnormalities as well associated with this, and there may be interventions directed at those as well.
Go ahead.
Either particularly with hypertriglyceridemia and using drugs to decrease triglyceride levels. And then potentially changing antiretroviral agents. If people are on those agents which are more likely to do that, then I would make efforts to, if you can, to change the regimen.
Now let me ask you about this. Do you use glitazone drugs for that?
I think, and that's to target the insulin resistance that you mentioned, which is very common.
And may have the effect of also improving fatty liver.
And
I've been taking pioglitazone for 2 years, and I think it's made a difference.
I think this is an area for which it makes a lot of sense as you look at how these drugs work and what they should do, that they should have an impact. And unfortunately, studies have not really corroborated that. And so it's I think, a difficult area, and I individualize that discussion. And I do have people in whom I have used glitazones in that setting, and I think you have to monitor liver function tests, and you have to do what you can to try to monitor the fat in the liver, whether that's through non-invasive tests or potentially even with rebiopsy.
But if somebody has frank diabetes or insulin resistance, then might you use pioglitazone?
Then they're the drugs of choice, I believe.
Well, that's why I took it, because I have diabetes as well.
Then I think of the drugs of choice. There are some people who believe in using them even without hyperglycemia, and I think that's an area that is more controversial.
So we only have, I think, probably 5 minutes left. Let's try and deal with depression a little bit. Depression is a big issue because interferon and ribavirin are associated with causing depression on therapy. A lot of people with HIV and hepatitis C have a history of substance abuse, which can be associated with depression issues or with other kinds of mental issues like that. A lot of people who suffer with that may not realize that they have it, but a lot of doctors, particularly hepatologists, not HIV docs as much, but hepatologists who are a little biased in dealing with this population affected by hepatitis, don't like to treat people who suffer with these problems. It's more complicated. However, because depression can occur related to the therapy, it's very important to address it up front. So one way to do it is to evaluate patients for their depression and then perhaps intervene with some therapy. And this can make therapy itself, interferon ribavirin, much more tolerable and much more successful. So could you talk about that a little bit?
Sure. I think it's a very important point. And just to emphasize what you said, because depression is so common in this population, if you eliminated, if you said that this was an exclusion for treatment, you would really be excluding people who need treatment from getting it. And so I think the alternative approach, which is the right one, is to deal with the depression. What we do is we use a depression screen on everybody who is co-infected, not just those we're considering for treatment, because we really try to consider everybody for treatment. We use an instrument that's called the CESD, which is a relatively easy depression screen to do, where you get a number from filling out questions. And it really is most useful in terms of following people over time.
So it's a questionnaire.
It's a questionnaire that you can do either by yourself as a patient or with your provider. It takes about 5 minutes to do. And we do it serially through treatment. And I think and that will identify people who, as you said, might not realize they're depressed or are certainly not being treated for it before they begin their hepatitis C treatment, so that you can target those people and use antidepressants if needed, or at least know that they need to be in counseling. Or, I think the statement that you need to be working with a psychiatrist is a pie in the sky one, because in our experience it's not easy to find a psychiatrist who is readily available, so we take that upon ourselves to do that. And we use a lot of antidepressants both before and during treatment. And the ones that you can use depending on what their side effects might be. So for instance, there are some antidepressants which will increase appetite. And for some people who experience a lot of weight loss during therapy, that can be a helpful thing. And so you really target the individual antidepressant to what the symptoms are of the patient.
And you're bringing up a very good point, and the point is that whoever is taking care of you, whoever your care provider or physician is, it's important that they understand how to use different types of antidepressants in your individual situation.
Without a doubt.
And so in the last few minutes, one last important question: how long do you give therapy for, and how do you decide how long patients should get therapy for? I did 18 months therapy in my PEG interferon ribavirin last time I was treated, which was 2 years ago. And talk about that a little bit.
Well, I think the standard approved dose of therapy is for 48 weeks, but we know that people with co-infection, one, take longer to become undetectable with their virus. And that's the major thing. And then oftentimes require longer courses to maintain undetectability, to reach cure. And so my approach to people has changed to I would say the normal quote-unquote course of treatment for an individual that I'm treating is for 18 months. And I think that you can show that because many of those people, if you measure their viral load, it begins to go down at 12 weeks, but they have not become undetectable potentially yet. And when you see that and it's still going down, I know that you need to extend therapy for longer. And so I think of it as it's 48 weeks from the time they reach undetectable, and for me that's often 18 months. And I have had some people who I've even treated for a little bit longer than that. If they were still going down at 6 months but not quite undetectable, then I'll extend their treatment out.
Well, thank you very much. This has been an excellent discussion about co-infection. If we had more time, we could talk about more issues. There's never enough time. But I want to thank you for watching Treatment Update 2006 from the 13th CROI, the Retrovirus Conference in the Rocky Mountains, Denver, Colorado.